Okay, I think we're going to go ahead and get started since we have a lot to cover today. It's great to see all of the names and positions and where you're all from in the chat. So keep it coming. It's fun to see some familiar names and someday hopefully some faces too. Welcome to our monthly National ACT virtual meetup. I'm Maria Monroe DeVita and joined by our co-facilitator each month, Lorna Moser. We'll go ahead, Lorna, we're going to say hi.
Hi.
We'll do a little more intro here in a minute, but we just wanted to make sure as we get started that we orient everyone to the agenda and then just some quick housekeeping. Today we have a wonderful topic, I think kind of inspired by many of the comments and questions people have had over the many months leading up to today. We're excited to have Dr. Sarah DeMeri with us today, covering the principles and practices of risk assessment, and she'll be introducing to us the START risk assessment and treatability tools. So that'll be most of the focus of today, but then we will typically kind of reserve the last kind of third of our time to focus on open mic questions. They don't have to necessarily be related to the topic that we're covering that day, but just an opportunity for ACT teams to either unmute themselves and ask their question or put it into our Q&A. So I'll cover that here in a minute, and then we'll just do some quick wrap up. Just a reminder that we are meeting again next month. We had been doing them every other month, but because of this particular two-part series, we wanted to kind of keep it fresh in everyone's mind. So we'll be meeting again for part 2 of Sarah's presentation on Monday, June 6th at the same time. Before we officially get started, just in terms of housekeeping, just due to the large number of folks on the call, all attendees are muted and you're not appearing on video. The chat box and the Q&A box will be available for your use. I'll explain more in a little bit in terms of how we want you to use each of those. And then just so you all know, the presentation is being recorded and the recording will be made available on our website after today's presentation. If you're experiencing technical issues, you can send a message through our chat to one of our staff. You can actually specify a panelist, and that should get to us so that you're not sending it to the whole group. And then there may be times when we ask you to share a response, or you might just have a general comment, and those all can go into our chat, assuming that you're not wanting a particular answer to what you type in. If you are wanting an answer and potentially either us responding directly, typing it out, or we may actually discuss it kind of live in the webinar, then we encourage you to use the question and answer box, the Q&A box at the bottom. That way we can track the questions that are asked and those that have been answered, and so we'll be monitoring that. And that'll be kind of at the end of today's presentation with Sarah, that we kind of will talk about those. So feel free, though, anytime to put them in the Q&A box. It doesn't have to be at the end, just so you know that it wouldn't be until kind of toward the end of our talk that we'll discuss those. All right, quick introduction. So we mentioned our names earlier. I think many of you are pretty familiar with us, but I'm at the University of Washington and the Northwest Mental Health Technology Transfer Center, and have done a lot of work in ACT training and implementation support, not only in Washington State with our training team here, but also across the US, and co-developed the TMAC. Some of you are familiar with that particular fidelity tool that are used in many of your states. And I'll turn it over to Lorna to make further introductions here.
Yeah, so it's nice because when Maria goes first on this slide, I just get to say ditto. Like everything she said, I do, but coming from North Carolina here with the Institute for Best Practices, where I'm joined with about 11 other consultants and trainers who do work across North Carolina, but also nationally in support of ACT teams, but also IPS supported employment teams as well. And yeah, so we're excited to be coming back with you all. And I think, as Maria just said, and I was seeing some fandom being thrown towards the START already with people who have been trained in it and have found it super useful, that with this two-part series today, I think today will be a little bit more focused on just risk assessment in general. You'll have to come back in June to really get a taste of what the START is. So I would love and happy to introduce Dr. Sarah DeMeri, who right now is the Senior Vice President and an incoming President at Policy Research Associates, or PRA. It's a certified women-owned small business that is a national leader in behavioral health and research and technical assistance and training. Previous to taking this position and moving all the way up in New York, Sarah was here in North Carolina, NC State University, a tenured faculty, professor of psychology, also the director of the Center for Family and Community Engagement, and coordinator of the Applied Social and Community Psychology Graduate Program. She comes with a background in forensic psychology, which has kind of brought her into this part of the field, and has authored over 130 peer-reviewed publications, which blows me away. That's prolific. It shames us, right, Maria? Has provided technical assistance, evaluation services, consultation to behavioral health, criminal justice, intelligence agencies throughout the United States and abroad. Current research focused on evidence-based practices for reducing detention rates, especially among people with behavioral health needs. Along with being a friend and colleague, we have brought her in to work with our ACT teams in the past here in North Carolina, because we see this so relevant to the work you all are doing. As you'll hear, part of risk assessment is about risk of violence to self and others, but there are so many other risks the people we work with face, and the focus here will be much more broader and give us something more structured to work with in terms of how we approach and support people. And I'd be remiss if I didn't also add that amongst all of her achievements, her and her husband just launched a farm brewery up in East Greenbush, New York, called Minor K over the weekend. So her coolness factor just went up a little bit more in my eyes.
Thanks, Lorna. Yes, and I'm also extra tired today. So I am very excited to be here. I jumped on the opportunity. Lorna literally didn't have to ask me twice to come and talk to you all, because I am really passionate about using risk assessment to improve outcomes. And I really see, oh my gosh, I can't even describe it, like a perfect match between the START and ACT. I think there's so much here. In terms of synergy and what we're trying to do. So like Lorna said, today I'm going to be starting with a very broad overview of what is risk assessment, how do I talk about risk assessment, and some principles and practices that I use when I think about how do we actually translate risk assessment into our practice in the community. I'm going to briefly introduce the START and touch on it today, but what I'm going to do in the next session is actually talk about how do you use the START to put these principles and practices in play with your teams. I also have to say and acknowledge from the get-go that I am a co-author of the START. However, I do not have any royalties or anything like that that come off of it. We put this in the public domain because we really wanted it to be something that moved the field forward, and we really felt like there was a need for the kind of work that we were doing. So today, what I plan to do in the next about 45 minutes is give a very broad introduction to risk assessment and hopefully disentangle a few kind of ideas about risk assessment. I'm going to introduce some risk assessment approaches and tools. I will talk a little bit about the state of the science, and I didn't want to shy away from talking about any kind of concerns or narratives that might be out there in the media, even in the news, about risk assessment, and to just really face those head on and talk through them. And then finally, I wanted to talk really about the whole goal as I see it when we're talking about risk assessment, which is really about risk management. I, as you'll see in a few minutes, don't view risk assessment as something that is done. I view it as a process that we engage in. And so I hope that today we'll have that foundation for thinking about how structured risk assessment can really be supportive and complementary to the work that you all are already doing. So by way of introductions, one of the first things that I like to do is just give a working definition, because honestly, risk assessment is talked about all the time, and we are very rarely talking about the same things. So I'm going to operationalize for us today just what I think of and talk about when I'm talking about risk assessment. So first of all, it is a process. In my view, it is not a thing that is done. So it's going to be ongoing, and it involves identifying factors associated with threats to public safety. And you'll hear me today talk about threats to public safety or recidivism or violence. And I'm sort of using those today as a catch-all for concerns about, threats to others. But I hope, as I'll introduce and allude to today, we're also very concerned about risks that might be facing the individual, the client, and more broadly, some overlapping risks. So I will be talking about threat to public safety to make things a little easier, but know that I'm thinking about it much more holistically. So you have to identify what factors are associated with threats to public safety for that person. Then you have to sort of take that information, understand how they're doing, and estimate some likelihood and severity of future threat to the public. This information then needs to be used to inform what it is that we want to do with the individual. And I'll talk a little bit more about what I think this kind of decisions are, or key decisions are in the context of ACT. Then you have to really engage in strategies to mitigate the risk. So here, I just want to be clear that when we're talking about risk assessment, I view the mitigation of risk as part of that process. Again, it's not one and done. It's something that you're going to be engaging in to hopefully reduce the risk and not see any of these issues of concern. And then ultimately, we have to keep an eye on things. One of the things that I find really pretty ironic or interesting is that folks shy away sometimes from acknowledging that the work that we're doing with them might, like the treatment, all of this hard work and contact that we're having with individuals might change the person's risk, right? That's the whole goal. We're doing intervention, we're doing treatment. We hope that people are getting better. Well, if that's the case, then we do really need to monitor risk and come back to it and hopefully say that over time, this person's risk has reduced. Of course, there's going to be situations in which that risk increases, that major life events happen, that there's decompensation, that there's external pressures that change how a person is doing. But all that to say, this changing kind of external and internal environment needs to be monitored in terms of what somebody's risk might be. So all this to say, whether or not you're actually using a structured risk assessment instrument, you are engaging in risk assessment. You, by your training and the work that you do when you encounter someone, you are engaging in this kind of risk assessment process. If you're not using an instrument, it might just be happening more subconsciously or sort of in a more organic fashion. And what I'm going to suggest here is that structured risk assessment will just help put some parameters around that and actually give you more to work with, more structure, more evidence, and more confidence in this space. So all of that to say, I am very much of the belief that risk assessment instruments do not replace decision-making. They don't replace your clinical intuition and the clinical judgment that you have developed over your years of experience. That is ultimately going to be what it comes down to. But risk assessment instruments can provide information that is evidence-based, that is usually more objective, and that can help you engage in a more defensible decision-making process, a process that hopefully you feel better about when you come to this idea of decision-making based on risk. So that is a lot to say that risk assessment is something you are already doing. I'm just going to talk about how we can use these structured instruments to hopefully improve that process. So where I see the role of structured risk assessment instruments are really in two places in this process. The first here is around the identification, analysis, and decision-making, right? So when I put those out before, then we talk about planning. What are we going to do? Hopefully we actually then engage in doing it. We have to monitor over time and review this risk assessment. So what I'm going to suggest is that risk assessment instruments can help in this early phase where you're deciding on and estimating the level of risk. And then in the planning phase, through a good structured risk assessment, you should have identified factors that are changeable, that are potential targets for intervention, that might either be risk or mitigating protective factors that then can inform what you do. And so these are the two key places for me that you can actually use the risk assessment instrument results to buffer up and support up what you're already doing. I wanted to also take the time to just clarify a couple key terms that sometimes get lost in this conversation. So I wanted to take a moment to tease apart this issue of screening versus assessment. So this first piece about screening is where we see the identification of individuals who are potentially at heightened risk. This indicates a need for further evaluation or preliminary intervention. And unfortunately, we have a really great real world example of this. So screening in terms of COVID antigen tests, right? We know that they can have a very high rate of false negatives, and that these are tools that then ideally you would follow up with a PCR test. So here, the ideal with screening is that we're casting a wide net and really trying to get people out of the kind of pool of people that we don't need to follow up with at all, that we feel very strongly are not at heightened risk, and thus we can just kind of move on. Assessment, however, is going to be much more comprehensive. It's going to be more in-depth, and it's going to take more time. It's going to consider individuals functioning across multiple domains, and it's going to integrate multiple sources of information. And so you might be saying to yourself, that sounds like a lot of work. I mean, frankly, it is, but it should be scaffolded on the work that you're already doing. So screening or risk screening will be very short, very succinct tools, often can be filled out, for example, based on records. You may not even need any contact with the client, maybe 5 or 10 items at most. Assessment, on the other hand, is going to involve this more comprehensive process. And I think that's really important to establish from the very beginning. These two can actually work hand in hand. So you might be in an agency or in your own practice, and they have a risk screening and risk assessment process. But you can't have risk screening in the absence of assessment, because the idea of screening is that it's always just a first step, right? So you have to then go on and have the full evaluation. If you rely solely on risk screening, you're going to way over-identify people as being at potentially heightened risk, and that can do all sorts of harms in terms of where they end up in their treatment, placement, decision-making, et cetera. So a couple other terms I wanted to just get a little bit of clarity on at the beginning of my presentation is this idea of risk versus other types of assessment. So when we're talking about risk assessment, and especially in this context, we're really making it distinct from focusing on one particular risk factor. So sometimes when I'm with folks and I'm doing training, they're like, oh yeah, we do a risk assessment, and they name a mental health evaluation tool. Or, oh yeah, we do a risk assessment, and then they name a personality assessment tool. But those are all examples of one factor that is going to be included with many other factors in a full-on risk assessment. So risk assessments are going to be much more comprehensive, and they're going to use a combination of factors. So they could include mental health, substance use, personality. They might look at cognitive functioning. They'll often look at the environment and peers. So it's going to be very multidimensional. It's usually going to be, like I said, longer, but it is very distinct from, say, just doing a substance use evaluation or a mental health evaluation. All right, so that's the background. I'm going to take just a drink of water, and then I'm going to move into talking about different approaches to risk assessment. So I'm going to do the very highest level. I always joke when I do this section of a presentation that I don't want you to tell my grad students or now my former grad students, because I actually teach a whole year-long course on this, but I'm going to give it to you in about 10, 15 minutes. So there can be, generally speaking, two broad approaches to risk assessment. The first would be unstructured professional judgment. Arguably, if you're not using an instrument already, this is likely what you're doing. So unstructured professional judgment is where the decision maker relies on their professional training and experience to estimate threat to public safety or violence or suicide or whatever. So it's not to say that they don't follow some, outline, or that there isn't some kind of strategy that is being used, but there isn't a specific tool that is sort of pulling the information together and helping that individual make a judgment about it. This is by far historically the most common way that people do risk assessment. Like I said, this is part of that process of risk assessment. And we know even to this day that there's still actually a renewed call perhaps to go back to unstructured forms of risk assessment. But I always want to remind people that we have had major concerns about unstructured risk assessment for over 40, 50 years. There's been a lot of work done started in the late 60s, early 70s, where we were starting to identify real significant issues in terms of what was happening with unstructured risk assessment. The first is that people with different backgrounds and different trainings are trained on how to do risk assessment very differently. And you can appreciate in ACT teams, especially, that you're all coming from different perspectives, you're all coming from different training. You could even have two, for example, psychologists trained at different universities, and they might go about this very differently. Well, that's problematic when we're thinking about, making decisions about people that could have very real consequences for their rights, for where they are, for the receipt of treatment, for placement decisions, but also for their safety and for the safety of others. With unstructured risk assessment, there is a real lack of transparency because it's very difficult for us as humans to really articulate what and how and why we're coming to these decisions. We might be able to sort of talk on some basic level about the things that we consider, but human decision-making is very complicated and complex. And frankly, we have very limited insight into how we make our own decisions. There can be a very big lack of consistency across people, but also within people, which ties into my next point as well. So we know that when we're making decisions and calculating risk or estimating risk in an unstructured fashion, and we're looking at different people, we, even if it's just one of us, might be doing that in a different way. So I might be looking at these people and looking at these kinds of characteristics, might be looking at these people over here and influenced by these characteristics, or here, this person's a friend of mine and I'm being influenced in this way. And so we're really looking at different things for different people, which leads us to concerns around susceptibility to bias. And this is really what was starting to kick off this work, is concerns that not only people were being evaluated and decisions for their rights and for where they were allowed to go and what they were allowed to do were being made very differently for different people, and not surprisingly based on some categories that we still talk about today, like race and gender. And perhaps maybe most, or importantly, or at least not the least important issue, was that we were finding in this research, again, conducted 50, 60 years ago now, that they had very poor accuracy in unstructured risk assessments overall. So some of the early work in this area in the late 70s and the early 80s was starting to find that not only was the accuracy poor, it was actually worse than chance. And so they did a few studies where they found that the accuracy with which people were estimating risk in these unstructured decisions was less than about 30%. So they were right about 1 in 3 times. So then Ennis and Litwack wrote this very powerful monograph that coined the term, pun intended, that we would be better off flipping coins in the courtroom. In other words, the accuracy with clinicians who were well-trained was only about 33%. And so it would be better off just to go into a court, flip a coin and say, yep, you're going to commit violence and you're not. Obviously, that is not a way to engage in clinical practice and professional decision-making. So I'd like to give this background because we have decades of research that now shows, and truly decades, starting in the 50s on, that statistical estimates are of human behavior. And I'm not saying that this is complicated machine learning or algorithms or AI or whatever you hear about in the news, but just basic statistics are better able to provide more consistent assessments of risk in terms of violence and crime, more transparent decisions because we know what factors are going into those models. They are more accurate, and they are also less biased because they're using the same information across people. Now, we'll get into some nuance there because, of course, the information that's going into these statistical estimates will influence the accuracy and the bias. However, overall, as early as the 1950s and as recently as to 2020, we're still finding that these statistical estimates of human behavior, and specifically of violence and crime, are more accurate than unstructured risk assessments. So just a reminder when we move further in this conversation, that risk assessment instruments themselves were developed to address these limits, these concerns about unaided human judgment. So these concerns about consistency, transparency, accuracy, and bias. So the second approach, very broadly, is this idea of structured risk assessment instruments. And these are not one thing. In fact, I'll show you in the next slide, they are many, many different things. But generally speaking, structured risk assessment instruments include a set list of items that are rated or combined in some way to produce risk estimates. And these diverse methods, they use diverse methods to combine and produce scores. Some are truly as simple as a checklist that are summed up and you count how many of these items you saw in the person and you get a total score. Other ones can be, hundreds of items long, use very complicated machine learning algorithms, which I completely don't understand, so don't ask me about it. But all that to say, there's a lot of different ways that this can happen. Sometimes they're paper-based, sometimes they're computerized. They can be filled out sometimes based on records alone. Sometimes they require interviews with the individual, with family, with collateral information. So there's all sorts of different ways that this might play out. What I would want to say is that they truly are accepted as the state of science and practice. So it really is the state of the art, and it has been for about 20 years. And I find it very interesting that there's this kind of renewed questioning, and I think it's important, about the use of structured risk assessment instruments. But we'll come back to some of that a little bit later. Okay, so wanted to give you all a few examples. And I know we're going to talk about the start, so I'm going to include that here, but I wanted to just give you like a flavor of the truly hundreds and hundreds of instruments that are out there. So we have tools that are specifically designed to predict recidivism risk. And here this means reoffending and generally just general offending. So no specific kind of crime, just these are individuals who typically have been previously convicted, and now we're looking at whether or not they're going to commit new crime. The Ohio Risk Assessment Instrument is one example. The level of service instruments is probably the most widely used internationally. The Compass is probably the most widely used in the States. Both of those two instruments include additional estimates or specific estimates related to violence. But I do want to clarify for this group that these again are focused on violent recidivism. So it's not any violent behavior, but violent behavior that would be counted and included in a reconviction, so that it is something that is coming into the criminal courts and counting as a new offense, which is different from what I'll show you in a minute about violence risk. So anyway, these are probably the top three that I have seen, but there are many, many others out there. And if anybody is interested, I have done reviews on, all the instruments that are being used in the US in terms of recidivism risk. Okay. There's a whole other kind of family or category of instrument, and they are designed to predict violence risk specifically. I would say probably the most famous one is the HCR20. And then, of course, the one that I was involved in is the START, the short-term assessment of risk and treatability. What's different about those two instruments is that they are structured, but they don't use any kind of algorithm or total score or any kind of mathematical process for creating a risk estimate. Instead, they guide the individual, they guide the assessor to look at these items, and then based on their review of the items, you still have to make a professional judgment. So it's an approach known as structured professional judgment as opposed to actuarial or algorithmic decision-making. But the idea here is that there's still a role for that individual clinical decision-making. And the other one that I mentioned there, the Violence Risk Appraisal Guide, is an example of an algorithmic tool that exists for violence risk. So the only thing I wanted to sort of clarify here about these ones is that they do predict violent behavior towards other people, but it doesn't necessarily need to be considered a violent crime in that jurisdiction. So here, the definition of what the behavior is, the outcome of concern, is based on the behavior itself, as opposed to any sort of criminal code or statute. Whereas the recidivism risk assessment instruments hang on what is considered a crime in that jurisdiction. We then have a whole other series of instruments that are designed to predict specific forms of violence. And I could go on and put a whole list of all different kinds of things, but I just wanted to highlight sexual violence risk here. The static 99 is a very common one that people may have heard of, used a lot in the US. But then we also have whole categories of instruments that are focused on domestic violence, that are focused on stalking, that might be focused on child abuse, separate from intimate partner violence. So there's really like a subset of all of these different types of violence risk instruments. And then lastly, I wanted to include some examples here of pretrial risk instruments, because this is, I think, where there is the most dialogue currently in the media around risk assessment. And if you're hearing anything or reading anything about risk assessment, it's probably about pretrial risk. So just to be clear here, what pretrial risk means is that these instruments are focused on identifying whether or not an individual is going to show up for their court date or going to engage in a new criminal behavior before their trial. So that's what this is about. This is a very specific period of time. So folks have been arrested for some crime, charged with some crime, but they have not been adjudicated and convicted of that crime. So it's a very kind of unique window of time that we're focused on. Two of the most common ones here are the public safety assessment and the Virginia pretrial risk assessment instrument. The Ohio risk assessment system and the Compass also have subsets of tools that are specific to the pretrial risk period. But I did want to clarify kind of what that means. So for the recidivism risk assessment tools, it means that the person should have already been convicted of a crime and now we're looking forward. The violence risk tools don't specify any kind of requirement in terms of what the person has been convicted of or not, or what setting they're in or not. And then finally, the pretrial risk assessment tools will look at a very specific window of time before a case has been adjudicated or disposed. All right, so that is your background. I think I pulled it off in about 20 minutes. Great. Don't tell my graduate students, or my former graduate students, I should say. So I'm going to now flip into a little bit about talking about what do we know about how risk assessment instruments work and what are we concerned about, or what is their concern about in the use of risk assessment instruments. So there is a lot of conversation, and I have frankly never been so popular, and perhaps not for the reasons that I ever wanted. I've been invited to participate in a lot of discussions with a lot of different folks about concerns people have around risk assessment instruments. And there's 4 specific concerns that I find myself addressing. The first, there's been a lot written and allegations made about the fact that risk assessment instruments simply are not able to predict outcomes, that it's a sham, that they are racially biased, that they're actually increasing punitive or restrictive responses, meaning that their use is resulting in more people being in detention in jails, in prisons, or in hospital settings, and that they are exacerbating racial concerns. So these are incredibly important concerns that we should really look at. And I just wanted to give you a flavor if you haven't seen, I mean, these are just some of the many different headings that you might have seen out there in the news. But New York Times has done a whole set of articles and op-eds on this, the problems with risk assessment tools. The Marshall Project interviewed me for this piece on racist algorithms. Can they be fixed? Philadelphia, Boston. And then the one in the bottom left of your corner, I wanted to just comment on because it really gets to my first point here about the science. It says risk assessment instruments, that's what RAI stands for, simply add a veneer of scientific objectivity and mathematical precision to what are really very weak guesses about the future. So in other words, saying that it's not possible to predict violence. All right, so based on these 4 concerns, what is the scientific question? And, you know, I think it's important for you all to know that I come to this work first as a scientist and a researcher. And then second, as somebody who just wants to get this work out in the field, right? So I started on this work doing research. And so there's really 4 key research questions that I see here. The first one is, do they have predictive validity, right? So are they unable to predict outcomes, or do they actually predict the outcomes they're supposed to predict? The second question is something we term test bias or predictive bias. In other words, do they predict differently for different groups of people? And here specifically for people of different races or ethnicities. So for the issue, for example, is usually framed around whether they are more or less predictive for Black people than white people. The question about increasing a punitive response for me is a framing of a question around effectiveness, right? So are these instruments effective in helping making better decisions? And ultimately, you know, as Lorna introduced, my work is about reducing detention rates and making less carceral and less restrictive decision-making. So are risk assessment instruments effective in that goal? And then finally, are risk assessment instruments and their use making racial disparities worse? So are they actually increasing the disparities that we see between Black and white people and other people of color? And so the scientific question, the research question here is one of disparate impact. So are they having different impacts on different groups of people? And I just want to echo that these are incredibly important concerns. And so one of the things that I've been doing for the last 5 or 10 years has been engaging in research to make sure and try to answer these questions as to whether or not we are seeing, you know, these concerns as legitimate and backed in science, or do we see risk assessment instruments and their results as being still the state of science and practice? So I'm going to very briefly walk through a summary of the findings, well, the question and the findings for each of these 4 areas. So the first one is predictive validity. And frankly, I'm a little stumped by the narrative in the media around this. Predictive validity is the degree to which the assessment results predict the outcomes they were designed to predict. So here, essentially, are they able to differentiate between people who pose lesser or greater risk of violence to others, or public safety, suicide, whatever the outcome of concern? The performance metric that we usually look at in these studies is the strength of association. So it's a statistical measure of the assessment results and the observed behavior during whatever the follow-up period is. So for the pretrial period, for example, that follow-up period would be until the person's case is disposed. If we're looking at reconviction or recidivism, if we're looking at violence risk, it might be a different period of time that we're looking at. But essentially, we want to know, does this assessment result actually relate to what the person did in the real world? So the reason I'm stumped about this is that there are hundreds of studies and more than a dozen meta-analyses looking at the accuracy of risk assessment instruments in predicting violence and crime. And so here I gave you just the sort of ones that came to mind off the top of my head. This is not a thorough literature review, but you can see that there are more than a dozen of what these meta-analyses are looking at predictive validity in this context. And a meta-analysis, if you're not familiar, is basically where you take a bunch of studies, you pull them together, and you run some statistics to see across all these studies, what is the relationship. So it's like a study of studies. And what we find across all of these different studies, that indeed risk assessment results have a moderate effect size, show acceptable predictive validity. So it's statistically significant, it's much better than chance, and perhaps most importantly, it's also better than human judgments of these same outcomes. So here we have studies of truly over millions of people over the last 30 plus years that show that risk assessment instruments do indeed predict violence and crime. So that's the first concern, which I do not find to be supported in the research evidence. The second concern is one of predictive bias, and I'm really glad that we're having these conversations because frankly, it's not something that I was ever taught about in graduate school or that we ever talked about, and we need to be better at doing this kind of work and asking these kinds of questions. So overall, the sum of the findings of the research is that peer-reviewed studies find very limited evidence of differences in predictive validity as a function of race and ethnicity, or as a function of gender also. So that's been looked at quite a bit too. When we do see some differences in predictive validity between groups, so in that degree of accuracy, it's not consistently in the anticipated direction. So when we find some differences in one study, it's not always the case that the performance is better, say, for white people than for Black people. Sometimes we see it in the opposite direction. When we do find differences in accuracy between groups, usually the differences are really small, both statistically and practically. And so to give you an idea of this, in one of my meta-analyses, when we looked at this in the context of pretrial risk, we did find a difference that was statistically significant between Black and white people in terms of predictive accuracy. However, remember how many people were in these studies and how many studies we included, and the actual difference meaningfully was the difference between a 0.67 and a 0.69. So meaning less than 2% difference, right? So that is a very small, almost negligible number when we take into account all the rounding and estimating that goes into that. So there's not really a lot of a difference there, even when it does exist. And then even more so, and more important, predictive validity remains good or better within groups by sort of a benchmark or a threshold. So in a lot of this work, we use a statistic that is called the AUC, and I'm not going to explain it. All I'm going to tell you is that 0.5 is chance and 1 is perfect. And so usually once we're above about 0.65, we're really happy with that result. Anything closer up to 1 would be fantastic, but we don't ever usually see anything above about a 0.75. So if we're operating between 0.65 and 0.75, and we find 0.67 for one group and 0.69 for the other, I'm thrilled, because all of that means that it's better than chance, it's better than unaided human judgment, and frankly, the difference isn't meaningful. Oops. So the last point here is that there's also a more complex way of really understanding the relationship of all assessment results across the entire group of people of concern. And again, I'm not going to go into the stats on this. I would be happy to share and discuss with folks who are interested. But there is a best practice approach in psychology, education, and evaluation more broadly. It's the identified way that you test for bias in these results. And we don't find any evidence when we use this method that there is really meaningful differences in the relationship between risk assessment results and recidivism or violence for different groups of people. So in other words, it means that the average risk score that we find relates to the average rate of violence or recidivism in the same way across groups. So that's a lot more statistics probably than you needed or wanted. But what I wanted to just share is that we really don't find this evidence of racial bias that folks keep talking about in the news. All right, so remember the third point was about effectiveness. So how is it impacting decision-making? Are we seeing more people incarcerated, more people detained, and more people hospitalized? So one of the things that we have to remember, and I'm going to come back to you all in the final section of today's presentation, is that it's not enough to do the assessment. You have to actually use the assessment results, right? So you have to actually use the results to inform decisions and interventions. Well, what do we know about judges and other decision makers? They don't always use those assessment results. They often ignore those assessment results. So a lot of folks have been looking at this, and I think there's been some really interesting work with a group of judges in Virginia, in fact, by Brandon Garrett, who is a professor at Duke Law, and some of his colleagues, and they found that judges were ignoring risk assessment results, especially when they had concerns of where would this person go in the community. So those of you who might be working in diversion contexts or other kinds of settings where we're looking at community placements, this is really what judges were saying in this study that they did when they were trying to dig into why judges were ignoring the risk assessment results. And they essentially said that I would be willing to divert this person based on the risk assessment results. However, there's nowhere in the community for them to receive treatment. So they coined this idea of the treatment resource hypothesis, essentially saying that part of why people are not using risk assessment results is this lack of divert to where, right? Like, where are people going to go in the community? Well, what we do see is that when people actually use the risk assessment results, outcomes improve. So there's been some really sophisticated, important studies that have looked at the degree to which a decision reflects the information provided in a risk assessment. And when that degree goes up, when that match goes up, we see reductions in restrictive placements, including jail, prison, and hospitals. We see a better match of the interventions to identified risks and needs. And importantly, we also see reduced rates of violence and recidivism. So in other words, when folks are making decisions that are in line with the risk assessment results, we're both seeing more people going into the community without increases in violence and crime, which is best case scenario. All right, and then finally, the last question is one of racial disparity or disparate impact. And so this is when decisions for one group are more punitive or lenient than decisions for another group. So the example I gave here is if Black people were less likely to be diverted to community settings than white people. So to establish this, we first have to look at whether risk assessment informed results are more punitive for people of color compared to decisions that were not informed by the risk assessment, right? So you have to know first what the baseline is to then understand what the impact of the use of the risk assessment tool is. And so the example I gave you there, Black people are less likely to be diverted than white people in risk assessment informed decisions than in decisions that were not informed by risk assessment. So that is the sort of research question that I would be testing, or the hypothesis. Well, what do we know so far? This is the least studied area in this work, and it's the most important, and there's really several ongoing large-scale studies looking at this. But what do we know so far? Risk assessment informed decisions are less restrictive, meaning more people are going into community settings with fewer conditions for people of color and for white people compared to decisions that are not informed by risk assessment. So in other words, again, going back to the previous slide, when folks are using risk assessment results and making decisions in line with them, we are seeing more people go into the community and getting community placements. There's really limited evidence that any risk assessment results are increasing the restrictive nature of decisions for people of color compared to decisions without risk assessment instruments. And finally, the thing that is sort of the most important to me here is that we are seeing that where there's deviation from risk assessment results. So in other words, when people are ignoring risk assessment results, it seems to happen more often for people of color. And this is not a solid finding, this is an emerging finding in the field, but what that suggests, unfortunately, is that it's not the instruments or the tools, the risk assessment instruments that are biased, but the people who are using them are expressing their bias in when they are willing to follow the risk assessment results. So I think that's really important food for thought for a group like you all who is here to learn about risk assessment instruments, is to remember that we have to check our own biases and the biases of other people in how we are using risk assessment results. But as I said, this is very early work in this area, and there's a lot more that needs to be done. So, summary of the scientific evidence here that I wanted to go through. First of all, they show good, not poor, predictive validity or accuracy. They show limited, if any, predictive bias. They actually contribute to less restrictive decisions, and they do not show racially or gender disparate impacts. So for me, it's important to always question the kinds of studies that people are talking about in the news, because frankly, they're not talking about good research usually, but also to make sure that we're asking these questions and doing this research so we have the evidence. So like I said, I've spent the last 5 to 10 years going back into the work to answer some of these really sort of contemporary important questions, and we're so far moving in the right direction. All right. So my conclusion is that risk assessment instruments, first of all, are not a panacea. They're not going to make everything fair and accurate and perfect, but they are comparatively better than the status quo. All right. So that was a very quick overview of the research. Now I'm going to wrap up today talking about these principles of putting risk assessment into risk management. So unfortunately, the bad news is that just implementing a risk assessment tool is not going to improve everything all of a sudden. As I talked about in the previous section on the research, is that you actually have to use the information to improve case outcomes. So my favorite framework for this translation from assessment to practice is the risk need responsivity model. So in the last sort of minutes that we're together today, what I'm going to do is go through each one of the principles and talk about how you can use that principle to support the translation of risk assessment to practice. And then, as I said, next month, we'll talk about sort of the case for, the justification and rationale for the START, and then how you can use the START to really put these principles into practice. All right. So the first principle is risk, the second is need, and the third is responsivity. So the risk principle, for those who are not familiar with RNR, the risk principle is the idea that you need to calibrate the level of intensity, frequency of supervision and services to the level of risk that a person poses to public safety and to themselves. So somebody who is higher risk should have more resources, more restriction, more services allocated to them. Somebody who is lower risk should have fewer resources, services, and restrictions. So it makes very intuitive sense. It's very logical. It is not rocket science in any way. However, it is incredibly hard to do in practice for a few different reasons. Why is it something that we should pay attention to, though? So I think we can all talk about cases in which we under-intervened or where we missed the risk, right? Those certainly are things that come to mind. However, what we don't talk about quite as much is that there is really compelling research evidence and clinical evidence that if we over-intervene, if we provide too many services, too much supervision, and too much restriction, we actually also increase the likelihood of adverse outcome, including violence, including crime, suicide, substance use, all those things that we're hoping to try to prevent. In fact, when we do over-intervention based on somebody's level of risk, we're actually increasing the likelihood of those outcomes. And there's a few different reasons why. So one of them is, well, two different reasons that I'll talk about. The first is that when we over-intervene, when we increase restriction, when we increase services and supervision, we actually present more risk factors for the individual. So the classic example is that people usually are not happy to have more pressures put on their time, to have more conditions put on them, to be monitored more frequently, and definitely usually are not happy to be going to a secure facility or hospital or anything like that. So in other words, we're making them angry. Well, what is the most robust, powerful predictor of violent behavior? It is anger. So one of the things that we're doing, and I'm not saying that, we can always avoid this, but one of the things that we do when we over-intervene is potentially increasing one of these really important risk factors. Some other things that we do when we over-intervene is reduce what protective, mitigating, or buffering factors folks might have had in their lives currently that we're actually making things better, not worse. So one of the things that is really a pet peeve of mine is that a lot of secure settings will take away privileges like access to recreation or anything that the person finds enjoyable as a punishment. Well, we know that leisure activity, recreation is an incredibly important and powerful protective factor. So when we're taking that away, we're actually taking away something that was preventing this situation from being worse, right? When we pull people into more restrictive settings, we're also usually pulling them away from opportunities to have contact with what potential positive peers or family or other supports they might have had in their environment. So again, the idea here is that we have to really think about and calibrate how risky is this person in terms of their violence, their likelihood of crime, and that kind of public safety question with how much we should be really doing with them. The other thing that just I can say from my own experience and my own work is that we tend to like to work with lower risk people more than we like to work with higher risk people. So we also might be naturally inclined to engage more, to have longer conversations and more kind of contact with these lower risk folks who actually don't need us very much. And we're less likely to put in all of that time and work because it's less enjoyable to be around these higher risk individuals. So a lot of different things to think about here, but I just wanted to sort of put this into your the back of your mind as we're moving forward with this idea of risk assessment in practice. So there are no risk principle guidelines. So even though that's what the slide says, just know that these are very broad strokes, generalizations that in no way are directives or standards. But what I tend to say to people when we're first getting into risk assessment is that if you have somebody who is low risk on whatever instrument for whatever outcome, that means that they don't need any attention related to that thing. So if you have somebody identified as low risk for violence, for crime, for suicide, that means that that is not an area of concern for us, and we don't need to do additional supervision or intervention around that. In other words, leave well enough alone. When we have somebody who is at elevated risk, so that there's some, non-zero, above low, moderate level of risk, then there is some kind of supervision and intervention required. Some examples there could be things like well-planned risk management and intervention. So maybe additional monitoring, short-term or problem-focused therapy. Really just kind of making those examples up. But the idea is that there should be something put in practice when you've identified somebody as being moderate risk. But when we have somebody that is being identified as high risk, then we're looking for more intensive and specialized supervision and intervention. And I just want to be clear that I'm not saying that somebody who is high risk has to be in a secure setting. In fact, I spend a lot of time arguing and working with diversion programs to help support them to ensure that they have the community resources available to divert high risk people, because those programs usually have a lot of intensive and specialized supervision associated with them that would be most appropriate for higher risk people, in fact. All right, so in ACT, I see this playing out in a couple ways, but the two primary sort of decision-making concerns that came to mind would be around the level of care, so where somebody should be. So presume the community, right? And then think about whether or not the resources are available, and always question then, is there a need to look at a more restrictive level of care? However, the presumption is that we're starting with this community level of care as a starting point. And then really, I think there's a lot here around case management. So how often, how many conditions, what kinds of supervision, what kinds of treatment. So really thinking about frequency and dosage across all of these issues. And again, unfortunately, there are no universal standards or guidelines, but there certainly are best practices as it relates to, intervention or levels of care for addiction services or things like that. Okay, so moving on to the next two principles. The need principle is very simply that you target the risk and protective factors that are relevant to violence for that person. And there's going to be a handful of risk factors. The risk assessment instrument, whatever one you use, will include a whole lot of risk assessment factors that, on the whole, research shows are relevant to violence. But it doesn't mean that they're all relevant to violence for that person. So part of this is coming up with a very person-centered understanding of risk. I will just add on the next slide that I really emphasize both criminogenic, so crime-related needs, as well as treatment needs, which is different from some of my colleagues, but in the context of folks who are often justice involved and who have serious mental illnesses, there's really an importance of considering both, and I'll show you that on the next slide. Basically here, when we see better match between the services that somebody is receiving and the actual identified risk factors and protective factors, then we see improved outcome, meaning reduced risk and improved quality of life. So it's a win-win. It's what everybody wants. Here, the only thing that I will say that'll lead us to our conversation about START at the coming up webinar in June is that I really think it's important to be able to engage and implement the need principle to focus and use a risk assessment instrument that allows consideration of dynamic or changeable factors, not static ones. So changeable meaning like things that are like mental health and substance use and attitudes and their mood, and not rely solely or even at all on historical static factors that can't change. Like I can't change the fact that this person was first arrested when they were 14. What I can change is perhaps do some intervention that might help their current substance use, right? So teasing apart what we can and can't work on. And then also focusing more on the proximal factors. So the things that are happening in their recent past as opposed to, again, more historically, because we know that what's going on right now is more relevant to what's going to happen in the near future. What's happened, 20 years ago for some folks, or, sometimes 40, 50 years ago for some folks, is less relevant to the near term for the planning and intervention. So the point I like to make in groups that we're working with people who have significant behavioral health needs and who are likely to be justice involved is to remember that we need to consider both. So we need to consider those factors that are related to their justice involvement, their violent behavior, but we also need to broadly remember their treatment needs. So behavioral health issues that might need intervention. And again, there's benefit to doing this because we can improve public safety, we can improve mental health outcomes by focusing on these quote unquote criminogenic issues. But if we also are doing commensurately the treatment for their behavioral health needs, those also can have indirect and direct effects on outcomes. So this is sort of a long way of saying that we have to consider both of these issues to really have the best bang for our buck, to have the most impact and improvement in functioning. All right, and the last thing that I wanted to talk about in terms of the principles is the responsivity principle. And the shortest way of saying this is one size does not fit all. And this means that we have to think about ways to tailor what we do with both the risk assessment results and then actually putting it into practice. So we need to think about how we can be most effective for this person in their current circumstances and really monitor how they're doing over time. We might try something out that they simply don't respond to. And what I think is interesting in this area of work, especially with people with behavioral health needs, is that we're very used to thinking about medication and changing up medication if it's not working, and trying new combinations and really tinkering with that over time. And for some reason, we're less likely to consider changing up the psychosocial strategies that we're using. And we tend to get kind of dogmatic and very fixated or committed to a certain approach. But I want us to be as flexible as we can, as we would be, say, with trying to tinker with the meds, as we would with our risk management and our clinical intervention. So there are kind of two ideas around, or two kinds of responsivity that we talk about. The first is general responsivity, which I'll talk about on the next slide. And then the second one is specific responsivity. So general is like overall, when we're working with individuals, what should we do as best practices? And specific is what should we do for this person? So in terms of general responsivity, the idea here is to use strategies that work. Of course, there's a lot of different strategies that have been shown to be effective, but this particular model emphasizes pro-social behavior through providing structure and cognitive social learning methods. The other thing that you want to say with general responsivity, and this I talk a lot about when I do START training, is that you've got to emphasize that relationship between the assessor, the provider, and the individual. And I always make the joke that you could be doing any kind of intervention, and the thing that's going to be, there's going to be two things that are going to be your best predictors of positive treatment outcomes. The first is a therapeutic alliance. So if we can really emphasize and engage and create a positive working alliance and relationship, that is, no matter what the intervention or approach that you're using, that will be associated with positive outcomes. The second, of course, is peer support. And, I think there's a very robust literature that shows that these two things, no matter what the type of therapy or intervention, if you have positive peer support and you've got a good working alliance, we're going to see, for most folks, a very positive clinical outcome. Okay, so that's general responsivity. So overall, we should be using therapeutic strategies that are evidence-based, that have been shown to be effective, that structure pro-social behavior. But then specifically for one individual person, we want to consider their circumstances. So we want to be able to respond and tailor our interventions to the person in terms of their culture, if they have a trauma history, gender-specific services. We might consider motivational interviewing to meet them where they are in terms of their willingness and understanding of their behavioral health issues and readiness for change. However, we also want to recognize that the environment around them can contribute to their treatment response. So there could be aspects of the environment, whether it's staff, characteristics of, where they're living, where they are, any kind of institutional or community cultures, or any broader practices. So anything that we might be able to affect or change in their treatment, their clinical environment, in the ACT team that might promote a better outcome. And there's always been, circumstances where we inadvertently are undermining the potential positive good that might come out of our work. And in this process, this is about really looking at those issues. So considering both the characteristics of the person and also their environment. And if you're doing a good risk assessment, you should actually be identifying these things. All right, so in the context of ACT, I think what's really important is that there's going to be a lot of responsivity factors. You're going to have a lot of folks with mental illness, with substance use issues. Most will have current symptoms. A lot are going to have acute symptoms. And so you can't do very high level work when you're first just kind of triaging around getting this person stable. And so that's an example of responsivity, meeting somebody where they are, focusing on that immediate sort of resolution of symptoms and getting stability, and then moving into more meaningful behavior change. And that's what I talk about here in terms of planning for safety first, then addressing acute symptoms, and then moving into deeper work to affect behavior change. And the idea that you can use a risk assessment instrument in this process is that you can actually use, to go back for a minute, use the assessment to help you look at and identify where somebody is and what are the factors that you need to intervene on and do work around at each one of these steps. And we can talk a little bit more next time about examples of what that might look like. All right, so looking at responsivity in ACT, we're going to anticipate change, hopefully change in response to intervention, but also change in response to somebody's life circumstances. Risk assessments and treatment plans, case plans are going to have a shelf life. So what we want to do is establish how we're going to revisit and come back to this over time, how we're going to monitor behavior, how we're going to operationalize what change looks like and in what direction, and then be ready to redo a risk assessment and update everything. I always argue that, if you're doing quarterly reviews or something, build on an existing process that your team already has in place, rather than trying to add in a new step or a new meeting or a new process. Just kind of make it work with what you're already doing. I often have said to people, and maybe some people on the call have heard me say this before, but you've got to make the risk assessment work for you. You don't work for the risk assessment. All right, so this all sounds like a lot of work, but I don't think it's about coming back and starting over from scratch. That is not how I approach risk assessment. So instead of pretending like you've never done a risk assessment on a person, this sort of re-administration or review might look like simply literally asking yourselves these questions. Okay, what's changed for better or for worse? What is the same? What strategies do we need to change, and what strategies do we need to continue? And if you go through and answer those 4 questions, you could very quickly update a risk assessment, especially if it's online, but also if it's just a paper copy, and be done with it. And I always tell people that I think you can do a re-administration or review in 5 to 10 minutes tops. So I really think that it's not as scary as it sounds. All right, so with that, I have wrapped up the didactic content and I am ready for Q&A.
That was wonderful. Lots of information in there. So much that we overwhelmed them into silence, I think. So you guys have some questions. We're getting a lot of kudos in the chat. One question I had while these folks write something up or get ready to pose something is, sometimes we encounter agencies that I feel like the agency itself has a culture of risk aversion. Mm-hmm. And that risk aversion can show up on how the expectations of the team's practice. Sometimes you'll hear the psychiatrist on the team put out there that, hey, it's my medical license at stake here. And so this lends to sometimes teams being a bit more possibly coercive, quick to use some type of intervention that is that over intervening, like you were speaking to, at the stake of trying to manage the risk. And I was curious if I would think that using a systematic tool actually could alleviate those risk concerns at an agency level, like allow the team to truly practice more person-centered.
Yeah, I have worked in hospitals and in community-based mental health settings for a very long time, as you know, and I see that a lot. And there's a few different things that I think we can do. I think it truly is, a culture of fear, I would say, even more than risk averse. And it operates in two ways. I see that it means that folks are less likely to recommend release or reducing restrictions or transitions to lower levels of care. But sometimes it also operates in the way that they don't want to do a structured risk assessment because they don't want to write down their opinions. So they don't want to have it written down. So to the latter issue, I always say, well, it's the accepted standard or practice. So I view risk assessment as a tool that supports you in the face of liability concerns, because you can show that you followed an evidence-based best practice. And, I usually spend quite a lot of time with folks helping them think about how to do that differently. The second issue is that I often put a lot of context around the risk assessment. So even when I'm saying that this person is low risk and I'm, let's say, recommending release into the community, I don't usually, or low risk might be a bad example, but I usually will say, given the current functioning in the current environment, and I also put boundaries on the time frame that I'm talking about, right? So I'm not forecasting, and this is what I hear with judges as well, that they're like, well, I'm going to be the one that the news is talking about if this person commits a crime in 5 or 10 years. And I'm like, it's not about talking about 5 or 10 years. What I view especially for ACT teams is what are we doing in the next 3 months? What are we doing in the next 6 months? And really operating in a risk management point of view. So the best thing you can do is identify those risks and then show that you've put things in place to address them. So I actually almost see it as a tool to help reduce fear and feel more professional protection. But that is definitely something I hear a lot.
A follow-up to that, we hear a lot of concern, kind of similar to what Lorna says, but kind of in a little bit of a different direction around just feeling very overwhelmed. And, we obviously have a lot going on in our, behavioral healthcare system, especially in public behavioral health right now, and a lot of turnover. And so what we hear often from agencies is that, it's actually potentially harmful to screen and assess and to use something like that, because if you don't have the intervention in place to actually address it, then what?
Yeah.
And so I would love to hear kind of your thoughts on that, because it's then seen as a reason not to assess again, because they don't have, we hear it a lot about suicide, but I think it's kind of translates to a lot of these other risks where they, what are you going to do then? You're documenting this, and then we don't have the training or the resources or, sometimes the time to implement something.
Yeah, so I hear that a lot too, and have for about 20 years. So I don't think it's just a now thing. I think it's, a reality, especially in public healthcare systems, that we're constantly overworked and underfunded. So usually what I do is step back to the beginning of the argument, and viewing risk assessment as a process. I would argue anyone working in these settings is engaging in some level of suicide assessment and some level of violence assessment with every person they interact with. It's not as if we're ever interacting with somebody, especially in a behavioral health crisis, where we're not at some level thinking about whether this person is a risk, right? So that is happening no matter what. And I try to articulate that to people as a starting point, because it's not as if not filling out the paper means that now we've done something differently, right? We're still doing that process in our heads. The more concerning thing is that we have, first of all, less
sort of evidence supporting that. But then also, I think it's important to document it, that from returning to the previous question, from a professional liability question, you know, if we're documenting that we think there are these concerns and these are the things that ought to be in place, that is important to be able to then fight for those resources and to also justify or articulate, because it's going to happen and it will happen. There will be those cases that, you know, are the worst case scenario where we see it happen into, you know, maybe they attempted suicide, maybe they were successful, maybe there was somebody released into the community that engaged in a horrific crime, all those things that we have nightmares about. And somebody who is engaged and met with that person isn't kind of off the hook if they didn't write it down. So I actually also then work with usually senior supervisors or kind of management level staff within hospitals to say that this is a strategy to document the services that you need, to document the level of risk and the level of training. And so I've worked with entire state systems. Actually, I did a training in Washington last summer for their hospital system, where we were talking about how do we then use this information to take it up a level, to get the funding, to be able to articulate that, you know, this is the level of risk that we see in our patients. These are the behaviors of concern. We're not doing anything about it. And it is, you know, a legal issue, frankly. So I've actually seen it go the other way, that we can then use it to fight for those dollars and successfully advocate for whatever the training might be. Because another thing that happens this time of year is I get a lot of calls from a lot of state and government agencies saying, we have X number of dollars, what should we do in terms of training between now and July? And, or whatever year end is. And my first question is always like, well, what are the needs of the patients and clients? Like, what are the presenting issues that you don't currently have addressed? And very often they don't know. So this is a starting point to start getting some sort of objective documentation, even if truly you cannot move forward. But it's a starting point to say, what do we need to do? Because it's not as if we don't do risk assessment, our patients and clients don't have these issues.
I'm going to ask one clarifying point, because I know there's some ears that may have heard something this way. Asking somebody at every encounter, are you feeling homicidal or suicidal, and then document it in a progress note is not a true assessment.
Right.
Okay. It starts falling on deaf ears when you ask something that routinely, it loses its whole meaning. Because I've met with agencies that is what the team members are instructed to do. And they think, I think it's for liability concerns. Yeah, that's actually a really good point, right? So that's why this whole field of risk assessment existed, because we found out that that wasn't the right way to do it, because that's the kind of thing that was happening 50 some years ago. And you know what, after, especially, people get desensitized, and we see, you know, we see it in all kinds of routine assessment when it's not a very nuanced assessment, when there's not room for this kind of professional judgment. That people just start ignoring it. Like we see it in jails, for example, with behavioral health screening, that especially with people who come back through several times, they're like, well, I told you last time I had mental illness, or I had, you know, I needed meds, but you just ignored me. So I'm not going to bother saying yes anymore. Right. Like there's a lot of reasons why people won't be honest in that kind of one-liner question. Well, thank you so much. This was amazing. And I expect that we're going to have 180 or so people back with us at least next month, because this was a perfect teaser to get us ready for the start next month.
And for those who couldn't join us, we will circulate your the recording so that they can get up to speed for next month. So thank you for allowing us to do that as well.
Yeah.
All right.
Great. Thanks again.
So we'll segue into just a little bit of open mic time. We try to just clear the floor up to just say, and it could be on this topic, but also can be off topic, because you all get access to each other right now to get some peer consultation as well.
And again, any topics, anything you want to ask of each other, feel free to raise your hand. You can see that at the bottom of your screen there, and we can unmute you, or you can put it into the Q&A.
I will Sure, because I know that some people had spoken that they had used the START before. One other way a provider here was able to use it is they had a managed care organization who was questioning whether somebody was appropriate for ACT. And when they had filled it out, they were able to say, oh no, look, these are the concerns we have that we're trying to help tamp down. Here's their strengths we're trying to build up. And here's the specific risks given their history. And so they actually were able to use that to make an argument effectively to an MCO for the case why that person needed to stay in ACT.
Oh, that's interesting. So more for like a continued stay
Yep.
with you kind of thing.
Mm-hmm.
And is that pretty common? Like, have people used the START for kind of, to some extent, that purpose? I mean, I realize people can still meet medical necessity to stay in a program. They don't need to, like, you know, have these elevated areas of risk within the START or other risk assessment tools. But
yeah, so I have seen it done in different places. I've also seen it in different kinds of community settings for these similar reasons. And then on the kind of converse, I'm seeing it used in a lot of different diversion programs, whether it's jail diversion or a forensic hospital diversion, where it's used to support people's transitions into sort of intensive community treatment settings. So in the similar way, both justifying them not being in the hospital setting, but also receiving a level of service that would come with the more intensive community or ACT kind of intervention in the community, as opposed to, you know, kind of routine community-based care.
somebody did have the question about where they get trained in the START. And I realize there's a little bit of an overlap with what we're going to talk about next month, but you want to share that.
So I don't have any open trainings planned at the moment. So usually it's me, but there is, and I'll share it next time, an online training, which is not specific to ACT or community-based treatment, but is a very general two-day online modular training that folks can do as a starting point. And then, you know, you can always reach out to me, frankly, and find out if there's any other trainings that are upcoming, because we do kind of do them in more of a pop-up fashion. The other way is that I get hired by agencies to come in. So I'm working with some behavioral health agencies in New York City currently, and I've done them for Lorna and her group and, you know, kind of all over. But more often these days, it's an agency or a community or a government kind of hiring me into their service to provide specific training tailored to that community or agency.
We have a raised hand, and I'm not adept at this.
Do you want me to do it, Lorna?
It'll take me 6 minutes to get there.
Yeah, and I also realize it may not relate to the presentation necessarily. So let me just grab our raised hands. Hold on one second. There we go.
You see it? I actually found it.
Oh, you did? Okay, go ahead.
Okay, Jane, I'm going to go ahead and unmute you. So you just have to unmute yourself. So Jane, and if it was an accident, just put your hand down and we'll know. Okay. Well, we'll assume it was an accident and then put it back up if you need to. Yep, there we go. All right. All right. Well,
I guess we're a quiet group. I think there's a lot to chew on between now and when you come back next month too. So I'll be curious to kind of hear. I mean, I really encourage everybody on the call today to just think about kind of how does this, affect kind of your work and any kind of practical, we recognize this isn't like a deep dive at all. So, the kinds of even sort of, what's next kinds of questions. I mean, feel free to kind of come kind of ready to go next month, just around anything else we can help to clarify. I know it's kind of a scary topic, I think, for a lot of people too. I mean, there's, it can feel a little uncomfortable, but I think, the more that we're, feeling like we can ask these questions and have, conversations about them, I think the more informed we will all be. And chances are your questions are going to be the same questions that other people have too. So I think we have just one more thing in the chat. Okay, good. So we've got somebody already saying they're going to summarize their questions before the next meeting. So perfect. Great. Well, yeah, go ahead, Lorna.
I was just going to say, for those of you who are familiar with the TMAC, the fidelity instrument, one of the items in there that looks at assertive engagement. This is what we're looking for in a lot of ways. It's that intentional, who potentially is not engaged and that is of concern, and how do you know and what are you doing? That's essentially what that item is trying to get at. And so not that this is anything about you'll score some extra points on the TMAC, but that's the part of practice within ACT that we're essentially looking for. And if you're using something like START, it absolutely would be hitting on that item.
Yeah, that's a good point. Good crosswalk to that. It's not about just getting a good score, but I think there's a lot of the reason that it's on the fidelity tool. So great. And it's something, I think one of the most common questions we get when we do fidelity reviews is like, well, what else is out there? How, what kinds of tools are there to be able to even kind of, assess risk over time or get a better understanding of how, best to engage or reduce engagement. And so having something like this, a tool like that is super helpful. So we will then again meet next month on Monday, June 6th, same time, same place, 12 to 1:30 Pacific, 3 to 4:30 Eastern time. Then we will not be meeting in July, and then we'll come back together in August. We've got some ideas percolating for August as well, but we'll want to kind of hear too from you all. We may pitch some of those ideas to you actually in the next call, or come up with another way to send that out to you all so we can get folks feedback for that next call. And the reason that there's only 2 more calls on this particular slide is simply because we're at the end of our federal fiscal year timeline with the Northwest Mental Health Technology Transfer Center. We'll also want to get your feedback on kind of how we move forward, if people like kind of this format and meeting every other month, or it was your feedback that kind of helped us to develop and design what we're doing this year. So we'll want your feedback on that as well. So we're not going away, but it's just a matter of kind of getting people's feedback as we go into another year of funding. And in the meantime, you all take care, and we'll see you here in a month on June 6th. Take care.
All right. Thank you.
Thanks again, Sarah.